Now let's come to the management of retinopathy. And the first and foremost thing that you have to do is screening of the patient. The problem with retinopathy, I repeat again, is that it is an asymptomatic condition. That is why screening is extremely important to pick up the patients of these conditions. First examination in case of a type 1 diabetic patient can be safely done 5 years after the diagnosis of diabetes mellitus, whereas in patient of a type 2 diabetes mellitus, it needs to be done immediately. The reason for this difference is that type 1 patients are more likely to be diagnosed early because they will show signs and symptoms earlier as compared to type 2 diabetes mellitus. Therefore, you can safely postpone the first examination by 5 years because you are not expecting any changes in 5 years. Whereas type 2 patients usually diagnosed late, usually diagnosed incidentally, that is why an immediate ophthalmoscopy examination is advised. If the patient is normal, which means no retinopathy, or if he has mild NPDR, once yearly review is sufficient. Moderate NPDR 6 monthly, severe or very severe without high risk characteristics, severe 3 monthly, very severe NPDR or PDR without high risk characteristics 2 monthly is sufficient. Whereas if there are high risk characteristics, then the follow-up needs to be tapered depending on the clinical condition of the patient. So it might be required once weekly or once every 15 days. So then it starts depending. Certain investigations that you need to advise before treating. First and foremost, the most common and common sense is the BSL profile. You need to do a fasting, postprandial, and a random blood sugar, urine sugars, 24-hour urinary protein to look for nephropathy. Lipid profile again, because dyslipidemia is a risk factor as well as a consequence of diabetic retinopathy. HbA1c to look at whether this condition is chronic, and a general hemogram to assess, to evaluate the immune status of the patient. So these are all biochemical investigations. Certain ophthalmological investigations is the FFA, which is the most commonly done. OCT basically to look for macular edema, intraocular pressure to see if the patient has a neovascular glaucoma and to just keep it in control, and gonioscopy if the patient starts if you're suspecting neovascularization at the angle. So now let's come to the actual treatment. There are 6 pillars of treatment in diabetic retinopathy. Each is equally important. There is no single each is important, but the single most important is metabolic control. The first is metabolic control. This is the most important one because this is the only modifiable condition in the eye, and controlling BSL today will help reduce the incidence of retinopathy later on. So a chronic control of the disease can be done with a metabolic control, and this is more of a physician's role as compared to an ophthalmologist. Certain goals that you need to achieve. First is in BSL, as you can see the numbers are there in front. Lipid profile again needs to be controlled. RFT is particularly important because it helps predict the existence of coexisting retinopathy. So if a deranged RFT is there, start suspecting nephropathy, and appropriately these investigations need to be advised. Blood pressure is one particular factor that I need to discuss. So BP in general needs to be less than 150 by 85, and particularly the ACE inhibitors or the beta blockers are very useful in case of diabetic retinopathy. So there's a 37% risk reduction if you use either of these category of drugs. Particularly, lisinopril is a drug that slows progression even if the patient is normotensive. So normal BP, still the progression of diabetic retinopathy is slowed down by lisinopril. And finally, certain lifestyle modifications that need to be made. Nobody does it, but you need to mention it in your answer. Okay, the second pillar is an intravitreal anti-VEGF. This has become the standard treatment, the gold standard, and the treatment of choice for diabetic retinopathy. Pegaptinib sodium was a drug that was used first as an anti-VEGF agent. Then came aflibercept, also known as Eylea. It is still used, but it is extremely expensive. So the two most common drugs that are used right now are bevacizumab, that is also called Avastin, with a dose of 1.25 mg, and ranibizumab, which is also called Lucentis, which has a dose of 0.5 mg. So it is very useful where laser therapy cannot be done, especially in cases of macular edema. You cannot directly give laser to the macula. That is where anti-VEGF comes in handy. Effect of each injection lasts about 1 to 1.5 months. Therefore, a frequency of injections is very high, and you need to keep giving injections until either the edema resolves or there is no improvement in the patient's vision. Now, anti-VEGFs not only stabilize the vision that is present, they also improve the vision over a period of time. That is why extremely desired, extremely preferable. However, certain drawbacks are present. The cost of the injection is very expensive, Single injection of ranibizumab costs about 25,000 rupees in the market. And if you're saying that the patient requires monthly injection or every 2 monthly injections, then it's quite an expensive venture. Aflibercept is even more expensive, which is about 45 to 50,000 per injection. So cost is an inhibitory factor. Second is the frequency. Again, you need to keep giving injections, and because you're increasing the number of injections you need to give, understand that you're entering the vitreous cavity with the needle and then injecting the drug. So there is an increased infection risk, there is an increased risk of endophthalmitis. Roughly about 1% risk is present. And understand that these are diabetic patients. These are patients who are already immunocompromised, who will have a poor immune system. On top of that, if repeated injections are increasing the risk of infection. And lastly, they are best avoided in pregnancy because their characteristics are not well understood and well studied transplacentally. The third pillar is an intravitreal steroid injection or an intravitreal depot insert. The most common drug used is triamcinolone acetonide 20 mg per hour, and they basically help to reduce the inflammatory component of diabetic retinopathy. So understand that there is a proliferation of blood vessels as well as inflammation that is happening because of PDR. So the steroids help to combat the inflammatory part. Again, repeat injections is a problem. Understand that it is a steroid that you're injecting, so there is a very high risk of steroid-induced glaucoma, a steroid-induced cataract, or an endophthalmitis again. Therefore, steroids are less preferred as compared to anti-VEGF. They are advised only if the anti-VEGF fails or if the patient is pseudophakic, because if he is a pseudophakic, there is a very less chance there is absolutely no chance of developing a cataract because we've already removed the cataract, and the risk of glaucoma reduces because again the anterior chamber is a little deeper in pseudophakics as compared to patients who have not been operated for cataract. The next pillar is laser. Single most important point that you need to understand about laser is that it only stabilizes the vision, it will not improve the vision. And which lasers do you use? You use double frequency YAG, which is 532 nanometers, argon green, and diode laser. The mechanism is basically to burn a part of the retina, to burn off a part of the retina, such that the hypoxic retina that is producing the VEGF is going to get converted into anoxic retina. So VEGF content decreases, angiogenesis decreases. Does it mean that I'm destroying a part of the retina? Yes, but there is a considerable overlap. I will plan the spots of laser in such a way that there is an overlap and the patient will have minimum problem in the field of vision. Second mechanism how it acts is production of anti-angiogenic factors from the retinal pigment epithelium cells. So there is an RPE pump stimulation. Two kinds of lasers are given. One is for diabetic macular edema and the second is for PDR in general, a more diffuse proliferative diabetic retinopathy. In DME, two ways in the laser in which can be given. It is either a focal macular laser or a grid laser. So focal is if the neovascularization is in a small area, whereas diffuse is that it is around the macula but a little larger. So focal is always a treatment of choice because you want to expose the patient to the minimum amount of laser as possible, because laser itself also has certain complications. So laser is contraindicated in diabetic macular edema patients if it is a case of ischemic maculopathy, because understand you are burning the retinal cells, you are burning the retinal blood vessels. So if the patient has ischemia, you will further worsen the condition. And secondly, in tractional diabetic macular edema, you do not perform a laser, you will go for surgical management. Let's deal with, in general PDR. So the procedure that you do is called PRP, pan-retinal photocoagulation, also called a scatter laser because it is scattered over a large area. Roughly 1200 to 1600 spots are given, done in sittings. You don't give all the spots in one sitting. It's usually divided into 3 or 4. So one sector will be done first. Each burn is about 500 microns in size, and each burn is placed one burn width apart. So if there are two areas of burns, they have to be separated by one area of, by one burn width apart. The inferior quadrant is always done first because understand that if you do the superior first, there's going to be some hemorrhage because you're burning the blood vessels, and that hemorrhage is going to come inferiorly and settle down. So you won't be able to access the inferior retina then. You will have to postpone the patient. So always do the inferior quadrant first and then proceed slowly, doing the superior one at the last. What are the indications for PRP? First is obviously PDR. Second is a severe NPDR, which is either bilateral or the patient is unlikely to follow up. So normally in NPDR, we do not give a laser because there is no proliferation of new blood vessels. But if the patient is from a distant village, he is unlikely to come to you, or if it is a case of bilateral NPDR, who will most likely progress to PDR in a short span, say in a couple of months, then give PRP. One-eyed patients, which means patients who have only one functioning eye, where you need to make sure that the vision remains. And lastly, neovascularization at iris, so NVI. So the image on the right side, you can see fine blood vessels that are running on the surface of the iris. You need to burn these blood vessels as well. So this is how scatter laser looks like. Right now the surgeon has done only the temporal and temporo-inferior quadrants. With due course, the entire retina will be involved. So these are white fresh dots that you can see. So these don't appear like typical burns. There is no tissue charring. There is just a light blanching of the tissue that you see. And say a couple of weeks after laser, this is how those laser marks appear, because now the retina has died. The retinal cells have undergone a necrosis. And this is a composite picture of the entire retina. So this is a grid, this is a pan-retinal photocoagulation of grid variety. So multiple, fundoscopy images are taken and made into this one. So I just thought it was a cool image to share with you. Okay, so one thing that you need to understand for any laser, that initially after giving laser, the vision will always worsen. This is because there is an edema that forms. However, this edema spontaneously resolves over 6 months, so there is nothing you need to do for it. And after any laser, the color vision and dark adaptation will worsen, but that is okay because the visual acuity of the patient will, remain stable at least, and there will be no further complications. So it's a small price to pay to maintain vision. So best results are currently, with the help of anti-VEGF treatment, with or without a steroid injection depending on the indication, and you do a PRP 6 months after initiating anti-VEGF, because the anti-VEGF itself will reduce much of the neovascularization, so the requirement of a laser reduces, and it has been shown that a delayed laser is more effective as compared to an immediate laser. Next pillar is the cryotherapy. However, it is not a very important pillar. It is the only indication where you might do is where PRP cannot be done due to a hazy media. For example, if there is a dense vitreous hemorrhage and you cannot access the retina with the help of a laser, that is when you will have to use cryotherapy. Single most important complication is tractional retinal detachment. Next pillar is surgical management for diabetic retinopathy. So when will you perform surgery on the patient, and what surgery will you perform? Tractional diabetic macular edema, which means the vitreous is exerting a traction, you need to remove this vitreous. So the procedure that you will perform is pars plana vitrectomy. You will cut the vitreous gel and remove it. If there is a dense vitreous hemorrhage which is not resolving, of course you will have to perform pars plana vitrectomy, because the blood is going and accumulating inside the vitreous. So removing the blood means removing the vitreous, so PPV will have to be done. The hemorrhage will have to be removed, and an endo laser is performed. So endo laser is nothing but the laser that we were giving from the outside. We go inside the eye because we are already performing a PPV and giving it intraocularly. So that is an endo laser, that is to seal off any breaks, seal off any tractional regions. If there is a presence of ERM, that is epiretinal membrane, you will have to do an epiretinal membrane peeling. The membrane has to be peeled off from the surface of the retina. Of course, PPV will also have to be performed, and so that the ERM does not recur, an endo laser is given. Finally, if there is tractional retinal detachment, you will have to perform retinal detachment surgery as appropriate, which will be discussed in more detail as a part of the separate topic. PPV again is a common feature in all these conditions, and endo laser as and when required. So just briefly, these are the surgeries that are done. That takes care of diabetic retinopathy. It has been an exhaustive lecture. I hope it is useful. Please follow us on Instagram at IXL. We are making efforts to post updates every single day to keep you updated. Subscribe to the YouTube channel to stay in touch with us. As always, thanks for watching. Stay safe. Good day.